Hey guys, am I audible and visible? If so, say me a hi and a hello. I hope you guys can see me. Yes, no. Okay, just give me a second. Okay, I hope I'm audible and visible. Very good evening, guys. So we are in one more episode of Pathoclinics. So I'll tell you what we are exactly going to do and what we have already done also, right? So we had a spin-off lectures of what happens inside the lab. In the first lecture, we talked about the light microscopy. In the second lecture, we had a look at your immunofluorescence microscopy and the immunofluorescence, how it happens, right? So today we are going to talk about one more thing. I don't have the pen tab today, so I'm going to look a little bit different. We'll be talking a little bit different, but yes, we'll be focusing on the core concepts of how to understand things, right? So today we are primarily going to talk something about frozen section, right? So before going to frozen section, can anyone tell me like how many of you have heard about frozen section? How many of you have heard the name frozen section? This is there. How many of you know the term frozen section? Yes, no, maybe. Come on, guys. I want you guys to interact. Like I said last time, we need more interaction. We need more activities in the chat box so that we can all have fun together, right? Hi, Munir. How are you? Hope you're doing good. How many of you have heard the term frozen section? And what do you understand by the term frozen section? You tell me that first. Then obviously we'll go into the uh, important aspects of frozen section and everything. You must have heard about the term frozen section, right? When we read about fatty change in the Nischay batch in the intracellular accumulation, I said that one of the important things where I can see fat, normally it's clear because washed away, I need a frozen section, right? So what we're going to do is we're going to talk about frozen section today. That's a primary goal here, right? So before going to frozen section, I want you guys to understand a tiny little concept called fixation. Fixation, like when you take a biopsy, I'll just not go into the hardcore science. I want you guys to just answer whatever comes to your mind, but I want you guys to interact, right? Munir, I don't want you to be a silent audience anymore, right? So when you take a tissue from the body, let's example, like I'm taking a piece of skin from my body as a part of biopsy, right? Investigative procedure. When I take it outside, this tissue, will it die or will it remain the same? What do you guys think? Will it die or will it remain the same? What do you guys think? It will obviously die, right? Because once it's outside of the body, it won't have oxygen supply, it won't have nutrition, everything will die, right? If you remember in your first year MBBS, the dead bodies were put inside something called as formalin, formaldehyde, the embalming fluid. I need the embalming fluid so the dead body will not decay. In technical terms, autolysis. Once you take anything from a body, it will automatically die. We call it autolysis. There is a solution called as fixative. Like the routine fixative, what we use same fixative. We use the same fixative. We use same formalin only. Formalin kind of prevents your autolysis, right? So we just use the same formula. Sorry guys. Okay, so I think I have to type it out this time. Sorry for it, right? We use formalin. Formalin or formaldehyde will make sure the autolysis will be prevented, because if formaldehyde is not there, by default whatever I have in the biopsy will die. So microscopy I'll see only necrosis always because it's tissue death. That's all, right? And also to prevent infection. I'm sure you'll agree that any organic material, fruits, vegetables, human body is also an organic material. You keep outside, bacteria, fungus, virus, everything will try to eat that, because entire air has every organism, right? So to prevent infection as a secondary role, the primary role is to prevent autolysis. But this has a problem. The problem is time. So now, if you take a biopsy now, this entire process of fixing the tissue takes somewhere close to 17 hours. We don't have 17 hours for a urgent report, right? If it's a routine report, yes, I can wait for 17 hours. That's why they take a biopsy today. The entire night it will be processed. The next day morning, it will have few more things called as putting into wax, cutting, staining. It will take minimum the next day for me to give a report. The minimum required time for me is 24 hours to report, because this fixation is a process. So the biggest disadvantage of fixation is time. Now, let's say that you are a surgeon, right? Imagine yourself as a surgeon in the operating table. You're looking at some lesion, some round lesion in the breast parenchyma. You are doubtful whether it's benign or malignant. You are inside the operation, inside the OT, right? You're taking a piece of tissue and giving to the pathologist saying that please tell me benign or malignant, because agar if it's malignant, you have to remove the entire breast parenchyma. Benign means I have to remove the tissue only. Can you wait for 24 hours? I cannot. I need an immediate report there, right? So whenever I need an immediate report, I need to give that to this consulting surgeon, consulting physician, whoever it is. That is the primary use case of frozen section, right? As the name says, it's frozen, right? Guys, come on, comment. So can I say, if instead of putting a dead body with embalming fluid and formaldehyde, can I put in a deep freezer? Will it also prevent autolysis? That's one more method, right? If any one of your relatives have passed away, till the everyone comes, they put in a freezer, because freezing a tissue also will stop the metabolism. Freezing the tissue also will prevent the autolysis. So what is the fixative here? Here the fixative is temperature. It's a temperature which is the fixative here. It's not anything else. I don't have formalin, I don't have glutaraldehyde, I don't have saline, nothing. It's just the temperature. The temperature here acts as the fixative. It's based on temperature, it acts as the fixative. The question is, at what temperature? Will it stay forever at 8 degrees centigrade, 5 degrees centigrade, 19, 20, or minus? What do you guys think? When do you think I can store a food for quite some time? What temperature do you think? Minus or plus? Guys, comment. Minus or plus? It's generally minus, right? The temperature is somewhere around minus 25 to minus 30 degrees centigrade, right? So when you have minus 25 to minus 30 degrees centigrade, then yes, there is a possibility for me to freeze the tissue, stop the metabolism, stop the autolysis. That's what we do in frozen section. And the machine what we use is Cryostat. The machine's name is Cryostat. This image can come in an exam and asking what it is. I have showed you the light microscopic image. I also have showed you the immunofluorescence, where you have the light from the top, right? That's also, next is your Cryostat or the frozen section, right? So now here, the Cryostat, if you look at this, if they ask any parts, you can see a glass top here. This is the freezing chamber, right? If I have to maintain minus 20 to minus 30 degrees centigrade, I cannot keep it open. I cover it. So inside the chamber is where all the specimens will be kept, specimens will be frozen. Minus 29, within a fraction of seconds, like 30-40 seconds, it will freeze automatically. It's minus 20, right? So you close it. And this is the microtome. You can see here a handle. So once it's frozen, once the tissue is kept, this is a wheel which will cut it into thin slices. Once it comes into thin slices, what we do? I do a simple, make it on a slide, and you stain. And once the staining is done, you give it to the pathologist to report. This entire process of taking the tissue, that's a biopsy, putting it into a frozen section, cutting it, making a slide, and staining will take 20 to 30 minutes. That's possible, na? So I can hold the patient in the OT theater for 20-30 minutes, okay, if I can get a report very, very urgently, right? What they will do is take a tiny bit of pieces and maybe slightly start dissecting the tissue, and they will know, it's malignant, let's do a radical surgery. It's benign, let's stop with this, right? So 20-30 minutes is the time required to report a frozen section, right? And this time is very, very important. If I'm going to take like 1 hour, there's no point in doing frozen section at all, right? This is something which you have to remember. It gives an immediate report, right? So how do we do it exactly? There's one important thing which you have to remember. This has not been asked in exams till now, but if it comes in exams in future, I want you guys to remember that, right? So what we do, I get a tiny tissue here, okay? Some random biopsy, same example, breast parenchyma biopsy, right? So once it goes there, so we have to have some medium. The tissues are very soft. You cannot cut something soft. If it's firm, you can cut, right? So what we do is, we take a wooden block, or there are few metallic material there. On top of that, we use this OCT. OCT is optimum cutting temperature compound. It's a compound made of resin and glycol, right? This is like a jelly, right? So on top of this, you put this jelly. Let's take a different color for the jelly. Hopefully I have the colors. Okay, not that, fine, ignore. So what we do here is, on top of this, right, on top of this, we put the jelly and we keep the same tissue here, right? So once we keep the tissue, then this goes into the chamber what we saw, right? This chamber. It goes to this chamber, and once it goes into the chamber, what happens? Using the microtome, we can cut them into thin slices, we can make into a slide, and then it goes with a rapid staining procedure. I don't do the routine H&E staining, because routine H&E staining will again take time, right? So we do the rapid staining. That rapid staining will help us a lot, will ease us a lot, right? So once we do that, automatically we'll get a report. Automatically the pathologist can see the slide, right? So now what are the use cases? I'm going to tell you 2 use cases, and I want you to remember these 2 use cases till you practice. And also one thing which can never happen in frozen section, that also I want you to remember, right? The first use case is something called a sentinel node biopsy, right? Guys, will you comment? This is the last time I'm asking, right? If you guys don't comment, I'm not going to go and talk about the next class, right? You guys, I want you guys to comment. If you've seen patients of breast cancer, okay, tell me which lymph node will breast cancer spread. I'll give you options also. Cervical, inguinal, axillary. If you don't comment on this, that's difficult. Where do you think the breast cancer will spread? Cervical, inguinal, axillary. What do you guys think? It will definitely by default go into axillary node. Na? From breast cancer, it's going to go to axillary node, right? So once a tumor goes to axillary node, right? Listen carefully and answer again. So once a tumor goes to axillary node, the surgeon is operating. The surgeon should remove the breast as well as the axillary lymph node, or only the breast parenchyma. I have to remove both because it's already spread here, right? If I leave it, it will spread further. So I have to remove. But the problem now, when you remove the axillary lymph node, the entire lymphatics is blocked. You'll have lymphedema here completely because there's no draining here. This is a draining path. I'm removing it as a part of surgery. So it's a very difficult condition for the patient. Lifelong the limb will be swollen. So how do I sort it out? That's where sentinel lymph node came. Sentinel ka matlab is first. That's all, right? So what the concept is simple. So I have a breast cancer here, right? So this breast cancer goes to axillary. You know about axillary lymph node anatomy, na? It is multiple groups of lymph node. But the first node or the second node, let's say I have a group of node here, okay? I have a group of node here, I have a group of node here. But the first node, what the breast cancer drains is the axillary node. Okay, it's definitely axillary node, right? This is what it drains to, right? Is the first node. The first node to which the breast cancer drains is an axillary node, is a sentinel node, right? So now what we do is high FACT. So now what we do is we take this biopsy, okay? Listen carefully. The logic is very, very, very simple. I take this biopsy of the first draining lymph node, that we call it a sentinel lymph node, and I give it to a pathologist in the form of frozen section. If it is involved, should I remove the axillary lymph node? Yes or no? If it is involved, should I remove the axillary lymph node? Yes or no? Obviously, we have to remove because it's already spread here, right? Let's say if it is not involved, should I need to remove? No, just follow up. That's all. That is sentinel lymph node biopsy, right? I can use it for multiple cancers. One thing which I want undergraduates to remember is at least breast cancer, right? So the role of frozen section is to not say what cancer is there. It's to say, in this there is present. In this there is absent. That's what. Present and absent. If the tumor is present, remove the axillary lymph node. Tumor is not present, don't remove the axillary lymph node. Logic is simple. This is the first node, na? Without involving the first node, it cannot involve this group. That's the logic. So first sentinel lymph node I'll take. That's one use case of frozen section. Second is margins of resection. Last time also we did talk about margins of resection when you went to light microscopy, right? And this margin to measure that stage use cases, to measure how much distance is from the tumor and the margin, right? So now what we do here is, so let's say I have done a tiny procedure. This is a tumor, okay? The entire black color is a tumor, right? And I have taken little bit of extra tissue also, right? Not just the tumor, I have taken a little bit of extra tissue also. This is grossly, na? Where the surgeon will think, this is the black color is a tumor, so a little bit of extra tissue they'll take so that the tumor will not recur, right? So now the goal is this margin, the extra tissue, is having really the tumor or not? So once the tissue comes to us, what we actually do is we take a little bit of sections from here and look into the microscopy via frozen, and we'll tell margins of resection is free. Same concept. Involved, yeah, not involved. If it is not involved, great for me. If it's involved, the surgeon has to go a little bit more deep and extract a little bit more. That's how the margins of resection is done, right? So these are the two use cases. Like I said, I never want you to forget with respect to frozen section, right? Next, This is important because it came in an INICT exam. What frozen section cannot do? Frozen section cannot diagnose. What does it mean? Can anyone tell me? We'll take an easy thing. Can anyone tell me what type of cancer you will get in oral cavity? Microscopically, what type of cancer do you think will get in oral cavity? What type of cancer will get in oral cavity? Squamous cell carcinoma, right? In a frozen, I cannot say, this is squamous cell carcinoma. I can say it is cancer, not what cancer. I cannot confirm the diagnosis. I can say, yeah, positive, negative, present, absent, benign, malignant, lymph node involved, lymph node not involved. I can never say this is the type of cancer, right? So it cannot be used for diagnosis. It cannot tell me it is adenocarcinoma, squamous cell carcinoma, columnar epithelium is there, it's a transitional carcinoma. I cannot tell. Sarcoma, lymphoma, I cannot tell. I can say yes, no, that's all, right? That's the only disadvantage of frozen section. Frozen cannot confirm because the fast procedure I'm doing, I'll just look for it. I won't go into the depths of it and I won't be able to give a report, right? That's about frozen section. We'll in the next class. Again, guys, I told you, I want you guys to comment. If you don't comment, next time I'm going to stop it. That's all, right? So since you guys are not commenting, I'm not going to take electron microscopy. I'll take electron microscopy for sure. There are two different types of electron microscopy. We'll look at them in the next class. Today, just a simple topic of frozen section. Fine. Okay. Any doubts? Do let me know. You guys don't have doubts also, na? No doubts, no questions. Very, very, very silent. I hope you guys learn something out of it. First, I need a fixation for any biopsy which is done. The only problem is fixation is a lengthy procedure. It will take like 17 hours to 24 hours. But if I need an immediate report within half an hour, I go for frozen section where temperature is the fixative and I can give a report within 20-30 minutes. There's the equipment where you can see that there's a place where the minus degree temperature is maintained and you put a tissue here, you use this wheel to cut and you have the slide, you can stain it and report it very easily. The other name for frozen section is Cryostat. Fine. OCT is the embedding thing, which is like you have a wooden block or a metal block. On top of that, you use this OCT gel. On top of that, you put the tissue. This is a biopsy. You put it, then you cut it and rapidly stain and give it to the surgeon, give it to the pathologist, right? Two use cases. It can tell sentinel lymph node involved, not involved, margins of resection involved, not involved. Based on that, the surgeon can make a decision. If the question comes, intraoperative techniques, frozen is an intraoperative diagnostic procedure. I can use it during surgery, not away. During surgery, I can take 20 minutes, I can give a report so the surgeon can take a call. But frozen can never confirm diagnosis, cannot say what type of cancer it is, right? That's a disadvantage of frozen, right? Okay. Okay, guys. Munir, Fakti, you guys are regular. I want you guys at least to comment on something so that we can take the discussion to the next level. Fine. So